ICU, which I've already heard are some people's worst nightmare. A lot of people are not excited about this kind of thing.
We're all thinking safe.
Yeah, exactly. So hopefully this will give you at least a framework in which to think about it, because I think that nobody expects you to be an expert in pregnancy in addition to everything else that you guys deal with. But at least a framework to think about these patients and to know what questions to ask, so that you're having the right conversation, even if you don't remember any specifics, which are constantly changing as with any field. So are most of you guys pulmonary critical care? I know you're stroke.
Anesthesia.
Anesthesia. Oh, cool.
Yeah,
We haven't met. Yeah. Yeah, that's how most of our fellows are right now.
Yeah.
It's exciting. Cool. Yeah, that is the new thing. Cool. So obviously you guys come at this from different trainings and different backgrounds, and so I kind of tried to make it relatively general. So this is the stuff that we're going to talk about today. It's a lot of stuff, so if I talk fast and I go over, I'm really sorry. But I am going to spend a little bit of time reviewing some of the really relevant physiologic changes in pregnancy, just because I find that with different backgrounds, some of you guys may not have really seriously encountered this in medical school. So it's good to review the stuff that's most relevant. Some of you are more familiar with it, so I apologize, but it's always good to highlight this stuff. This general approach to the ICU patient is not mine. I actually got it from a 2015 paper, which I'll talk about when we're there. But I really, really liked the way they organized the thought process around this, and so I kind of just put it in here. And then I go through a couple specific conditions. Obviously, you can give whole lectures on any one of those things, so they're very, very brief. And then we'll end with some ACLS basics. So why you should actually listen to me, unless you're just terrified of pregnant patients and want to actually know more about it, is because you probably will take care of a pregnant patient in the ICU, whether you're in neuro doing strokes, or you're in the MICU, or you're in some other thing. You probably will take care of it. All this data is from ACOG's 2016 practice bulletin, so the numbers may be more updated since then, and they just haven't published them. But the important thing, so I'm going to try to use this pointer. I think that the most important part of this slide is that maternal mortality in the U.S. is increasing. And with that, I think that you're going to find more people getting into the ICUs because pregnant patients are getting sick, or they're having more critical illness, or they're in kind of end-of-life experiences. And so you're going to see this probably more and more because of that. So this is some CDC data. These charts go through 2014. The most recent things on their website are actually through 2015. But you can see from 1987 to 2014, we basically have a steady increase in maternal mortality in the U.S. And there's a lot of reasons and a lot of people working on that. And I'm not going to go further into it because that's, of course, another whole lecture in itself. The 2015 data actually went down to 17.3, so there's a little downtrend, but I don't know that that's going to be a sustained thing. It's kind of, the general trend is up. And then this chart here, on your right, is their analysis of causes of pregnancy-related death in the United States. So these are the kind of things that you might be looking at. And later under cardiac disease, I'm going to talk about this more because two of the things are actually cardiovascular disease and cardiomyopathy. They split them up for some reason, but if you combine the two, cardiac disease is actually the leading cause of maternal mortality in the United States. And the same is true for a lot of developed countries. And you can see some of the other causes here that you might have to deal with. And so this is the result of a lot of analysis of like state level data as far as pregnancy-related mortality in the U.S. So once we know all of this, the next question we ask is, can we actually do anything about it? Are people just really sick and they're dying and there's not a whole lot we can do to intervene, or can we do a lot? So this particular graphic is from California Pregnancy-Associated Mortality Review. A lot of states have these. California is particularly organized and is a leader in publishing pregnancy-related data in a lot of different ways. But there also has been published very similar data from a collaborative of 9 other states' PAMR committees, including Ohio's, and they say very similar things, which is that a lot of them, there's at least some chance that you can alter that outcome and prevent a death. So the blue is a good to strong chance, and the red is some chance of altering this outcome. And you can see for most of the causes, overwhelmingly, these review committees felt that there was at least some chance, or a really good chance, that we could have altered the outcome had certain things been done. And they go further into it and try to identify the ways in which it could have been altered. And a lot of it is both provider and system specific, and a lot of it is not escalating care, not consulting when you do, kind of failure to recognize how sick a person is. That's kind of my personal summary of all the different things they broke it down to, is that sometimes it's really difficult to tell when a pregnant woman is that sick. And sometimes that's where that opportunity comes in, is by the time they really declare themselves, it might be too late. So we'll talk about some of that stuff a little bit later. I just wanted to review this really quick. Obviously right now we're all at the kind of tertiary referral center that we get all the patients sent to us, but that may not be true for the rest of your careers if you go somewhere else. If you go to a more community center, one of the things you might have to think about is when you can keep a patient and when it's reasonable to send them to a higher level of care when they need more than your hospital can provide. And I think that a lot of people almost feel like this is a personal failure, like admitting that they personally can't do this, and I think that's not true. You have to think about what resources your hospital and system has and what you can provide for the patient. So this is ACOG and Society for MFM's levels of care for maternal care. And they basically set forth, kind of like trauma centers or other type of centers, kind of requirements for what level you should be considered and what resources that you have to have available. And so we, I think, would be considered a level 4 center. We have on-site pretty much everything all the time. And that's kind of what you need. You need on-site, like medical and surgical subspecialty consultation. You need MFMs who are critical care trained or involved in the management in the ICU. But levels 3 and 4 are really the only ones that would be even expected to provide ICU care for patients. And so if you're at a place that does not have a lot of these resources, then you need to think about maybe sending them before they're about to deliver, in which case no ambulance will overtake them, and then you're kind of stuck, which I've heard those stories before. So this is a good thing when you first get this patient, unless you're here and you can't send them anywhere, is this the best place for them to be? And if not, then what is the best place for them to be? What kind of things do you anticipate them needing? All right, so pregnancy physiology. I'm going to start with cardiacs. It's my favorite. I like this particular slide because it goes through based on weeks and the physiologic changes that accumulate over the weeks of pregnancy. And so in general, cardiac-wise, you have to increase your cardiac output in order to supply oxygen delivery to the fetus, as well as all the mom's metabolic demands. And so over the course of the pregnancy itself, cardiac output will increase by about 50%. And that's both an increase in heart rate and in stroke volume and plasma volume. And you can see that in this picture. Let's see, this is cardiac output, increases until about somewhere between 28 and 32 weeks and kind of levels off for the rest of pregnancy. And that'll be relevant to people who have pre-existing heart disease because that's really where their plasma volume is expanding to the maximum point, and that's when you need to watch out for them. So that's pretty relevant. You can also see that down here, peripheral vascular resistance, SVR, blood pressure actually dips through a lot of pregnancy, comes back up a little bit at the end, but their blood pressure is actually going to be lower than they were even at their baseline, and that's pretty normal for pregnancy. So pulmonary, this is very brief and basic, but there's an overall increase in minute ventilation, again, to meet the metabolic demands of a growing fetus, and so it's about 20 to 40% increase over the course of pregnancy. And this is, again, increased tidal volume and increased respiratory rate. And so it kind of acts a little bit like a restrictive lung disease because your lungs are physically restricted from expanding, which I can tell you from personal experience. And so your baseline ABG in pregnancy is actually going to show a mild respiratory alkalosis. So if you're getting blood gases here, like these numbers that I put up here are actually pretty normal. So if they have a nice like 7.4 or 40, whatever, that's actually not super normal in pregnancy. And so if somebody has that, then something else might be going on. And you can see based on this picture here why you would have a decrease in a lot of these lung volumes and capacities. So decreased FRC, decreased expiratory reserve volume, residual volume. There's just no room for any of that with the baby taking up all the space. And so for someone like me in anesthesia who intubates people or manages airways and stuff like that, what that means to me is that I have a lot less apneic time when I induce somebody, or if you're intubating somebody in the unit, you have a lot less apneic time before someone desaturates. Because the FRC is really where all that extra oxygen kind of sits for us. And so I have seen people desat way faster than you would ever expect, and trainees get really, really nervous about it when they hear that sat going down. And that's kind of expected, unfortunately, in pregnant women, especially if the airway takes a little bit longer to secure than you would like it to. So moving on to airway, the bottom line of the slide is that you should respect the pregnant airway and not take it for granted. This is not to say that you can't intubate pregnant people or that every pregnant person is going to automatically get a airway. That's not true. What is true is that they will have increased airway edema and friability, and that our Mallampati scores, which is our method, our method of assessment, they increase during pregnancy, and then again during labor and delivery process. So if you're getting someone who's like immediately postpartum, they've been laboring for a long time, this is the same patient during their labor at the beginning and at the end. Like this is the exact same person with these pictures taken at the beginning and the end. So it shows you how much all that stuff can change. But even during pregnancy, you can have an increase in your Mallampati score and potentially difficult airways. So what I will say is, in somebody who you think is probably going to be straightforward, it's probably not going to change a whole ton. But if somebody were like kind of borderline anyway and you're a little concerned they might be difficult, and then you add pregnancy on top of it, or you add laboring on top of it and all the fluid and all the extra stuff that's happening, you should be pretty concerned that they might actually be very difficult. And so I just have a lower threshold for video laryngoscopy, having some backup, surgical backup if it gets really crazy, awake intubations, things like that. But yeah, please just respect the pregnant airway. Renal. So the increased cardiac output results in increased blood flow to the kidneys, and so your GFR is actually increased by about 50%, and that means your creatinine values, if you were to check them, should actually decrease, and so 0.5 to 0.7 is normal, and I've heard a lot of the obese say if your creatinine is getting back up to 1, even though that might be otherwise normal for that person, that's actually not great during pregnancy, and they start to get concerned about that, especially in the setting of some of the hypertensive disorders of pregnancy. And gastrointestinal, I just thought this picture was really funny because it's totally true. So you do have a reduction in lower esophageal sphincter tone due to progesterone. So that means that instead of anything stopping your gastric contents from going up, nothing is stopping them from going up. And so you have a lot of reflux, even if the person's not physically experiencing it. It's pretty common. So you have increased gastric pressure, increased acidity, normal gastric emptying, but there's just a lot less space for it there. So that's why people get full a lot easier as well. And so we consider them to have greater potential for aspiration past about 20 weeks. That's about the size that everything gets pushed up enough and there's enough progesterone in the system that these changes become significant. So we do rapid sequence intubations for patients after about 20 weeks or so, which is awesome for the whole decreased FRC oxygenation thing, but it is what it is. All right, hematologic. Overall, pregnancy is a hypercoagulable state, so you have increased risk for deep venous thrombosis. They do have increased plasma volume. They have a dilutional anemia, but an increased red blood cell mass. So their plasma volume increases more than their red blood cell mass. They have more red blood cells than normal, but their hemoglobin might be lower, and that's still reasonably normal. Obviously, an anemia down to like a hemoglobin of 8 is not just because of pregnancy, but and they do have a mild leukocytosis as well. And so you can see that most clotting factors increase. A couple of things decrease. Platelets will decrease as well. And protein S, which is anticoagulant, will also decrease. And so you have to be real worried about DVT potential in pregnant people, especially if they are admitted to you in the ICU. I know you guys do DVT prophylaxis anyway, but these people are at a higher risk even than your baseline patient in the ICU. And I just want to quickly mention about fibrinogen. A normal fibrinogen in pregnancy is like 400 milligrams per deciliter, as opposed to like 200, which you see now. If somebody is bleeding and they get down to 200, that's actually an independent predictor for severe postpartum hemorrhage. So we'll, I guess, go into a little bit that later about what the massive transfusion protocol looks like. But just so you know, like I think people who don't see this a lot are like, oh, like they have a normal fibrinogen level, things are fine. Actually, it's supposed to be way, way higher than that. So, so that's just something to keep in mind. I don't know about the fibrinogen. Generally, we say all the physiologic changes take 6 weeks to totally resolve, but I know like von Willebrand factor, when it goes down pretty fast after delivery.
So we've had the postpartum hemorrhages, they're like the postpartum like health PICs,
Yeah.
are with a higher fibrinogen, but I didn't know how far out that was.
Yeah, I don't know how far each specific factor takes to decrease. I would say in the setting of postpartum hemorrhage, since they do mark it as an independent predictor for severe postpartum hemorrhage, I wouldn't expect to be like within hours of delivery. So I would assume that it would at least go through like the, yeah, I would, especially in that immediate postpartum period. Yeah. So these are just some expected laboratory values, and you can see the difference between pregnant and non-pregnant people. And I'm just going to let you guys, I'm not going to read them all off. Obviously, some of them are a little bit different than your typical, like the PaCO2 and your white blood cell count. But the reason I put this up here is because on the next slide, I'm going to put up the search criteria. And I do this knowing full well we are not really relying on search criteria for that much anymore. But it's an interesting illustration of how some of the normal values in pregnancy actually overlap with stuff that at least historically we use to try to mark the severity of illness or sepsis or some sort of diagnosis. And so in a lot of these, some of these numbers could be normal in pregnancy, or they could indicate that there's some sort of pathology going on, which I think highlights sometimes how difficult it is to tell if a pregnant woman is really sick or not. Because if they're kind of at the borderline of all this stuff, are they just trending down, or is this just kind of where they live during their pregnancy? So it can be really hard to tell. Unfortunately for my illustrative examples, source criteria, like I said, are not used nearly as much anymore, but it's an interesting thing. So this is a general approach to the pregnant ICU patient. This was published by a team from Baylor, who I think has a lot of experience with critical care obstetrics. I've listened to some of them talk at meetings and spoken with some of them. They actually have like regular simulations on pregnant patients. Like they actually have a pretty well-developed program. And so they've kind of put forth this 5-step approach that I'm going to go through in some of the coming slides. But one of the things I thought was interesting is what are you going to have to deal with? If they're admitted to the ICU, like what kinds of things are you going to be treating? And it turns out that a lot of them are obstetric causes. So, you know, pregnancy is not a benign thing for women. It can come with its own issues, preeclampsia and HELP, eclampsia, hemorrhage, and then sepsis from a GU cause that's related to their pregnancy. So they kind of classify that as an obstetric cause versus the non-obstetric causes that anybody can have, but they either may be worsened by pregnancy or they're more susceptible to something like that during pregnancy. And that's only about 1/4 of the cases. So these are the kind of reasons that you might see for some of these patients being admitted to the ICU. This is a lot of things. It's a busy slide. I actually, if you're interested in this at all or you want like a background, this is a really good paper. It's a series of 2 papers actually. They're really good to read if you find yourself looking for more information on this topic. But what I want to highlight about this is that they kind of split it into how the condition is related to the pregnancy. So you can have conditions unique to pregnancy, so those obstetric indications that we talked about. You can have something that's totally unrelated to pregnancy over here that they just happen to have, and I think like drug abuse and trauma are probably common ones that we would see here. You can have things that maybe they're a little more susceptible to during pregnancy, so like DVTs and PEs, aspiration, infections because the pregnancy is a relatively immune suppressed state, or you can have a pre-existing disease that might worsen because of the normal physiologic changes of pregnancy. And so obviously in my mind, heart disease is foremost among those, right? Patients who have pre-existing heart failure don't really love this volume load that you get during pregnancy. But you can also have some respiratory, endocrine, hepatic things that worsen during pregnancy because of physiologic changes. And so these are kind of buckets that you can put these patients in if you're trying to make sense of them in your head. So the next question is, where should they go? So have any of you guys seen a pregnant patient here, like during your fellowship yet? So there's always this huge discussion before they get to you about where should they go? Where are they best served? And they think the textbook answer is they should go to whichever ICU they would go to if they were not pregnant, right? Because theoretically, whatever their underlying disease is, that's where they're best served, is the unit that treats that particular thing. Now, do you think that's what happens in reality? Not always. Sometimes it is. Sometimes it is. But this is very, very dependent on where you are and what people are comfortable with and actually the physical makeup of your hospital. And so I will tell you here, there's a very strong bias from our OB colleagues for the SICU because a lot of the patients end up going there. A lot of the problems that they face are addressed by the SICU. And so that's where they end up going. It's on the 2nd floor. It's right by the ORs, which is very comforting to everybody. And that's where they have the most experience. No, but they know that staff better. They have a lot of experience there. And so they're comfortable with their patients in the SICU because it's the most common place for them to go. There is no policy here that says they have to go to the SICU, just so everyone knows. And I have taken care of patients in the CVICU and the MICU, if that's the appropriate place for them. But that just requires a lot more discussion, and it requires that the severity of their underlying disease really be very prominently cardiac or pulmonary or something like that, as opposed to something that can be managed in the SICU with a consult service. If you go other places, the physical layout of the hospital can actually really come into play. So I've talked to a lot of people where like I may say, oh, like this person needs to go to a cardiac ICU, and they say, well, at my hospital, it's a completely different building than any OB service. And so the OBs couldn't come over and even take care of them if they were in that ICU. So that kind of rules that out. So you also have to think of just practical factors like that. Like, can they actually physically get the obstetric care they need if they go to an ICU in a different building, or like, could, all these things happen. So kind of have to get the lay of the land wherever you end up and figure out like what's actually possible there.
When you do fetal monitoring in any of the ICUs here, you just bring like a OB nurse up to do the fetal monitoring?
Yeah, so the way they do it, as long as this works, is they do it remotely by it's like telemetry.
Oh, yeah, so it's like watching the monitors.
Yeah, so they have a nurse assigned downstairs to be watching it. If that doesn't work, then yeah, the OB nurse has to come up and like physically watch the strip. But usually the way they do it here is remotely. So you may not see the nurse, but they're there watching the strip. Yeah. All right, so this is our 5-step approach when you get these patients. And these are kind of the different things to consider. And a lot of these things, I'm not going to necessarily say this is how you manage this patient, but it's more like these are the conversations you have to have and these are the questions that you have to ask. So I think in the end, like I can't tell you how to manage every pregnant patient because I don't know what they're going to come in with. But it's good to know what kind of conversations you have and what kind of things you're thinking about. So this is that paper I was talking about. This is part 1. There are 2 parts. But like I said, if you actually want to read more in your abundant free time, as fellows, I recommend these. And then also Society for MFM just came out with a really good one that I'll bring up later that I really liked. And it's a little shorter than these 2 papers. So the first one is there a medical or obstetric cause? And so that goes back to some of the things we talked about earlier as far as what you're actually treating, because your management is going to be very different if it's a primary obstetric cause versus a medical cause, right? If it's an obstetric cause, then delivery is going to be a lot higher on your list of conversations because delivery can at least improve or halt or hopefully cure whatever is going on with that obstetric cause. Whereas if you do that and it turns out to not at all be related to pregnancy, then you haven't really done anything except, I guess, remove a further stress on the patient's body, which is never, I guess, a bad thing. But there are some examples of things that can overlap, and so sometimes it's not always easy to tease out if this is related to pregnancy or not. So a lot of like postpartum hypotension. Are they bleeding? Is their heart failing? Do they have an AFE? Do they have a PE? Like, is this related to pregnancy or not? You don't know. And so sometimes you just kind of have to think of all of those different things and just figure out which one you're treating so that you know where to start. Is there multi-system organ failure? Is there just one thing going on? Are they just bleeding and you have to address that? Or have we gotten to the point where they've become a little bit more of your typical ICU patient? They have more than one system that's going down. And these are 2 systems that I think are more notable during pregnancy. The first one is DIC. That's what it's supposed to be. And the second one is acute renal failure. And I just put those out there because those are systems that like the DIC thing, I think is a little more common in pregnancy and postpartum than it might be in other patients, and so it's something that should at least be on your radar. And the kidney thing I basically just put up there because, like in the physiology slide that I talked about earlier, their creatinine is supposed to be lower during pregnancy, and so you have to have a little bit more of a lower threshold to look at that and be like, hey, maybe their kidney's not doing as well as I thought, even if the values look way better than any of your other patients in the unit. So the third question is, and the next couple slides are really going to be about conversations that you're having with your MFM or your obstetric provider or whoever is consulting, because somebody should be, by the way, on these patients. You don't have to do this by yourself. You don't have to know everything about obstetrics. But there is a lot of conversation, depending on gestational age, about continuing the pregnancy. And so obviously if they come in like first trimester, pre-viable, actually that's still a conversation you might have to have, unfortunately. But are there risks to the patient in continuing the pregnancy? So for the obstetric causes of illness, like we said, delivery might actually improve the maternal condition. If somebody has severe preeclampsia or eclampsia, you need to get that baby out because the placenta is part of the problem, right? That doesn't mean that your risk goes away after that, but that's part of the problem. So that's a relatively clear-cut thing. If the maternal condition is deteriorating to the point where she can't support that fetus anymore and you're viable, or even not viable because the fetus might die anyway if they can't, then do you need to move up the delivery? To fetal distress, what time frame do you have for intervening if you find fetal distress? We'll talk about that a little bit more with monitoring. And then literally the worst time for any of this is periviability. I hate this. When I was at like 24 weeks, I was like, God, I just want to get past this so I don't have to worry about making any of these horrible decisions because it's a terrible time, Outcomes for the baby at this time are not great. If you can hold on even for a week or two, it really improves neonatal outcomes. And so the balancing act is mom versus baby and trying to maximize both of their outcomes. And it's a hard conversation to have. And so that's going to be always kind of on the radar with these people if they're still pregnant is, should they still be pregnant? And at what point do we say there's no benefit to them being pregnant anymore? Or the risks of them being pregnant outweigh the benefits? And so a lot of times in these conversations, what you come up with is a goal gestational age to say, you know what, like based on how they're doing right now, our goal is to get to 30 weeks or 34 weeks or whatever, depending on where they are, with the understanding that if a lot of this stuff changes, that gestational age may have to change, you may have to move up the delivery, but you might just have like a goal to get to saying we're not going to go past this date if they're that sick or they have that severe underlying condition. So how do they get delivered? And of course, because I do anesthesia, I have to talk about anesthesia. But about 70% of critically ill patients get a C-section, which is not really surprising, right? A lot of the reason they're in the ICU is because they're critically ill. Inductions and vaginal deliveries are by their nature unpredictable. And then if you need a stat C-section, nobody wants to do that in an ICU room. And a lot of times you can't get quickly to an operating room. And so it makes a lot of sense that that would be the case. Over, like, I think like about a third of deliveries nationwide are C-sections versus 70% here. So when they do have the cesarean delivery, they will have to have anesthesia. And I know that you guys are not necessarily involved in that because we come and we do this, but just for your general background and information, for all C-sections and all deliveries, we do prefer regional anesthesia over general anesthesia. For a vaginal delivery, if they are a candidate to have one, and sometimes this is the case for our sick cardiac patients that I take care of a lot, having an epidural can actually reduce the stress on the heart because it reduces your blood pressure, it reduces the swings that you have during contractions as far as like sympathetic tone and heart rate. And it allows for an assisted second stage, so a forceps delivery or a vacuum assisted delivery, so they don't have to push as much in Valsalva. They can do that much more comfortably if they are numb down there than if you try to do a forceps when they can feel everything. And so as far as a C-section, a spinal or a CSC provides good surgical analgesia or anesthesia. That's what we do all the time in labor and delivery. And it avoids the risks of general anesthesia, which you can see down here. We are able to control how fast that spreads, which can minimize the physiologic impact of a spinal. So a spinal, like everything happens real fast and they can get hypotensive and you take out their sympathetics. If you do a CSE, you can dose that much slower and kind of avoid that. So for sicker people, if I have time, that's usually what I prefer. General anesthesia, we can do safely if needed. So I don't like scaring people and saying we can't do it. We just prefer not to because there are these increased risks: aspiration, failed airway, fetal exposure to anesthetics, which is not a small thing, especially in a preterm fetus. Increased intraoperative blood loss. So our general anesthetics actually relax the uterus. And after delivery, in order to stop bleeding, you need to not relax the uterus. So you might have increased intraoperative blood loss as well. So reasons that I would definitely do a general anesthetic: if you're coagulopathic, then I will not stick a needle in your back. If you have respiratory distress, you can't lay flat, you're already intubated, things like that, then obviously I'm not going to do a spinal. Or systemic infection, bacteremia, sepsis, something like that, because I don't want to introduce that into the CSF. It'd be bad. I get seizures, things like that. So those are like major reasons that I would do general anesthesia. Patient refusal obviously is a contraindication for any procedure, but I would say the most common reasons we would do it are coagulopathy, or patients receiving anticoagulants, or that they can't lay flat during the procedure. But if they can do all of those things and they're okay with staying awake, then I prefer that way.
Would you consider coagulopathy? Like if you have an ICU patient who's on like sub-Q heparin or Lovenox, and then for some reason needs an emergent delivery, is that a contraindication still?
It depends on the dosing and how long it's been since they got it. So ASRA, which is our Society for Regional Anesthesia, actually has guidelines about how long it has to be stopped. So if they're on like prophylactic Lovenox, like 40 a day, then their dose has to be 12 hours before the delivery.
Okay.
Otherwise, we aren't able to do it.
Just go to general.
Yeah, you just go to general. Yeah. I think if they're on therapeutic Lovenox, it's 24 hours, and then the sub-Q heparin is like 4 to 6. Heparin drops you 4 to 6. But you can check PTTs for heparin to see if they're a candidate, depending on how much time you have. Yeah, but for Lovenox, it's either 12 hours or 24 hours. Yeah. So then the next question is, as the ICU doctor, you know, there's a lot of conversations about delivery and when you're doing this and where you're doing this and anesthesia and what we kind of need. And so your job in all of this is to optimize the patient as best as possible so they can tolerate this delivery. Because I went through a lot of physiology of pregnancy, but it turns out that during delivery, there's a lot of physiologic changes that happen right then that are not spread over 9 months. So your cardiac output increases by another 50%. When your uterus kind of contracts, all that fluid that's like in the walls and has been lurking around goes right back into your vascular system. So it's like a huge fluid bolus for really sick people right now. So there's a lot of things that are happening around delivery, and so part of your job is to help optimize. So in conjunction with everyone else, trying to figure out when they're going to be delivered so you know what time frame you have to work with, what your goals are. Giving betamethasone for fetal lung protection is super important, especially in the earlier gestational ages where they're viable. The outcomes for babies who have steroids on board versus not steroids on board is very, very different, especially at like the extreme prematurity. So that's super important. I put some of the weeks here that you should think about it. But basically, like if they're not termed past 37 weeks, then it should at least be part of the conversation. The most important thing is to optimize their hemodynamics and volume status. And I just talked about the volume load just after delivery. So if someone comes in with like heart failure or pulmonary edema or something like that, please diurese them. And then when they come back to you, don't be surprised that they're not as diuresed as you had sent them to us, because that's just physiologically what happens after delivery. Correcting coagulopathies as much as possible. I know this is like a throwaway, optimizing other organ function. I'm not going to say you had to do your job, but in general, that's what you're trying to do so that they come through the delivery as best as possible. So what about fetal monitoring? Should you have fetal monitoring in the ICU? So that is not a straightforward question, and we deal with the same thing in the OR. Should you monitor a fetus during anesthesia if they're having non-cardiac surgery? And so there are a lot of things you have to think about. And this is all discussion with your MFM or your obstetrician or whatever, because they're the ones who are going to be providing the personnel, as you said, the monitors and the backup and everything. And so you have to think about, first of all, when the fetus is viable. And right now we say like peri-viability is 22 to 24 weeks. 23 to 24 is when we start having those serious discussions. And the NICU team would be involved in those discussions as well, at least here. And so if somebody is pre-viable, generally they'll just say like daily heart tones, just to see that continuous monitoring is not super helpful as far as determining fetal well-being and guiding your interventions necessarily. The other question is, why do you want to monitor? So are you actually looking at fetal well-being? Are you saying that, you know what, if this fetus starts looking like it's in more distress, we're going to intervene and deliver the baby sooner? Then that needs to be kind of a clear endpoint in your discussion. Are you going to use it as a marker of maternal well-being? So is it just like another marker of end organ perfusion, which I guess in the strictest sense of fetus is a marker of perfusion and end organ function? I know it's weird to think about it that way, but it kind of is, right? Because you can measure perfusion in that way. So if that's why you want to use it, then it at least needs to be clear to everyone, hey, if things start looking badly, then we're going to adjust whatever we're doing to optimize maternal perfusion, but not necessarily intervene or deliver the patient. So those goals need to be clear with everyone who's involved as far as what you're doing. So if you do decide to monitor, then someone trained to interpret fetal tracing should be, monitoring the strip. So either they're in the ICU with you or remotely by telemetry, which is generally what you would expect here. And if you have decided that if the baby takes a turn for the worse and you're going to intervene based on some sort of finding, there should be an in-house obstetrician who can intervene, right? It's not going to do any good if you say, wow, they're having these late D cells, like the fetal status is actually really bad. Let's call somebody and it'll take them 45 minutes to get here. That's a little more difficult, right? That's hard to do. And so in general, you should have a plan at least for who's going to do the intervention and what time frame that it should happen over. And ideally somebody is in-house if the intervention should be happening quickly. And if you've had one of these patients in the ICU, then you have probably seen that you have a baby warmer, neonatal resuscitation supplies, and a crash C-section kit sitting outside their room, ready to go in case they need to do a crash C-section or a perimortem C-section, which we'll talk about later, in the ICU room, which has happened. So that kind of stuff should at least be like by the bedside. So this is an example of a fetal heart rate monitor. So the top is the fetal heart rate. The bottom is a tachometer that measures uterine contractions. And so you can see here that this is a pretty normal fetal heart rate. It's between 110 and 160 beats per minute, but there's good variability, which measures the health of the autonomic nervous system. And so there should be that variability, usually between 6 and 25 beats a minute. If you're doing continuous monitoring on a fetus that's less than 20 weeks, this may not look like that because their autonomic nervous system just isn't developed yet in order to show this. And so it's not going to be as reliable. This is what happens when you sedate a fetus. And so I show this. This is like a fetus under anesthesia. That's kind of why I show it. But it's also true if you're sedating a patient in the ICU that you see you kept your heart rate, but you've lost your variability. And that more reflects the depression of their central nervous system by the sedation of the anesthetic more than it does the actual health. And so it's hard actually to make a lot of judgments when they're sedated based on variability. And so you may have to just base it on decelerations or drops in the fetal heart rate. That may be a better indicator of fetal distress if you have a lot of sedation on board. All right, we're going to go through some specific conditions really fast. I could lecture for probably an hour on like every single one of these. But I'm going to start with heart disease, which, as I kind of mentioned earlier, if you combine the cardiomyopathy and cardiovascular condition, is the leading cause for maternal mortality in the U.S. So it's a pretty serious problem. And it's one that we need to take seriously. At this institution, we actually have a combined multidisciplinary clinic who takes care of these patients throughout pregnancy. So we have MFM and cardiology and anesthesia get together once a month and basically create care plans for these people. And some of them with more severe underlying cardiac conditions do end up in the ICU around the delivery, after their delivery, not just because they do badly, but because we need them to be monitored more than they can be on a labor and delivery floor or on a postpartum floor. If you guys have ever been on a postpartum floor, it's not a hospital in the same sense that the rest of the hospital is a hospital. And that's not to knock them, it's just not the point of it, right? Like usually these are relatively healthy women who come and deliver and are doing fine, and you need to just make sure that they're not having any obstetric complications, monitor baby, everything. Like they're not meant to be in a hospital because they're not sick, they just had a baby. But when they are sick, then it's not really set up to do that. And so sometimes you'll get someone and you're like, gosh, like they're doing fine, like why are they in this ICU? It's because we're watching for bad things to happen, because that's when bad things might happen. So this is the modified WHO classification of heart disease in pregnancy. There is actually a decent amount of literature for this topic on risk stratification of heart disease in pregnancy. And most of the scores actually try to identify individual patient factors and then create like a number. It gives you a number like risk thing. This actually breaks it down by just what the underlying maternal cardiac condition is. And this one in multiple studies has been shown to be more accurate than the others at predicting cardiac complications during pregnancy. And so basically there's a lot of writing on here, but I circled the 3 and 4, the WHO 3 and 4 categories, because those are the more severe underlying maternal cardiac conditions and the ones you're most likely to see in the ICU. So class 3 is the most severe case that we actually feel comfortable saying, yes, you still can get pregnant. The class 4 people, we recommend that they not get pregnant because maternal mortality and morbidity is so high. It's like pulmonary arterial hypertension is a perfect example of this. It has high morbidity and mortality during pregnancy. So if these people get pregnant, then we generally would recommend termination for maternal health. But not everyone listens to that kind of thing. Some people want to get pregnant and have babies no matter what we say. And so a lot of times we do have to take care of patients with these things. I have taken care of actually people with a lot of those conditions during pregnancy because they either present too late, they didn't know, they don't want a termination, or they knew they weren't supposed to get pregnant, they said, screw it, I'm going to do it anyway and stop all my pulmonary hypertension meds, which has totally happened here. They should probably not do that. If they want to get pregnant, they should actually like come to medical care. But pulmonary hypertension, severe LV dysfunction, so like BF less than 30%, previous peripartum cardiomyopathy with a residual defect because the risk of worsening during a subsequent pregnancy is very high. Severe aortic dilation and Marfan syndrome because the risk of aortic dissection is pretty high during pregnancy in those people. Those are the people who are the class 4s. Class 3s, just thinking like a moderate LV impairment, like 30 to 45%. Like I've actually seen people like that do reasonably well during pregnancy. Mechanical heart valves, they have a big anticoagulation issue, so that's a pretty high risk pregnancy. Moderate mitral stenosis, asymptomatic severe aortic stenosis. So like there are a lot of, kind of high risk cardiac conditions that have a lot of potential for things to go wrong, included in here. So I talked about some of these other studies that identified individual patient factors. I'm not going to go through them all. That would take me a really long time. But the ones that I put up here are basically ones that a lot of these studies have identified. These kind of keep popping up over and over. So if you've had prior cardiac events, if you've had episodes of heart failure that you're admitted for before, if your baseline New York Heart Association is more than 2, if you have left heart obstruction like aortic stenosis, mechanical valve, pulmonary hypertension, these people tend to do less well and have a higher risk of a cardiac complication during pregnancy. And when I say cardiac complication, for the most part, what I'm talking about is either an episode of heart failure or an arrhythmia that occurs during pregnancy. So those are the 2 major complications that you would find yourself having to manage if your patient's still pregnant. And heart failure tends to happen in that period that we talked about where they're kind of in the early 3rd trimester, like their volume has increased the most it's going to during pregnancy. you're either going to see it then or you're going to see it immediately postpartum when they have that big delivery rush of increased cardiac output. And so this figure, I really like. It's better than anything I could probably write down on a slide for you. This is from the European Society of Cardiology's guidelines on cardiovascular disease in pregnancy. They actually have a comprehensive document. This just came out, the most recent version, last fall. So a year ago. That was a year ago. But the reason I like it is because they start with just a general patient evaluation. You know, look at their vital signs, look at their mental state, look at their lactate, see how sick they look to you, right? And then you can do EKGs, you can do echoes, you can do all that stuff to further quantify what you're seeing with your eyes. And then based on those two things, they split you up into two kind of tracks. And so there's stabilized heart failure, where they may be, you know, admitted with heart failure, but not like totally circling the drain. And then severe destabilized acute heart failure, cardiogenic shock. And so what you're going to do is going to depend on what kind of bucket you put them in, right? So if they're in stabilized heart failure, then you give them standard heart failure therapy. You diurese them, you reduce their afterload. Obviously, there's certain medicines like ACE inhibitors that you probably shouldn't use to do those things while they're still pregnant. But you're still doing the same general principles. And you're talking about when you're going to deliver them based on your heart failure thing. We much prefer to stabilize people instead of saying, oh my gosh, they came in heart failure, let's deliver them right now, for reasons that I've discussed earlier. We much prefer them to be stabilized a little bit before. If they are postpartum, then they can get more of the standard heart failure therapy without the medication restrictions. There are actually a couple ACE inhibitors, let me see, enalapril maybe, that are reasonably okay with breastfeeding if that's something the patient wants to do. But they can get more of those medications without having to worry about teratogenesis or fetal toxicity. But go ahead.
What's ICD therapy?
It's like an ICD.
Oh.
Sorry, I forget what it actually stands for. But it's basically prevention for malignant arrhythmias. Yeah, so either, I'll talk about it on the arrhythmia slide, but basically like they say you should get an ICD during pregnancy if you need an ICD during pregnancy, but some people just end up with a life vest until they deliver, which is super annoying. So the severe cardiogenic shock pathway might be what you end up managing a little bit more. And so I'm going to highlight a couple things in here. Is that if you're in this pathway, urgent delivery is much higher on your discussion list, right? And so it's a timing thing, but it's going to happen a lot sooner than it is in a stabilized patient. So obviously you're optimizing their preload and optimizing their oxygenation and doing inotropes, suppressors, all the things that you would normally do as a measure of ICU care. As an aside, there's not great evidence for inotropes and suppressors as far as their safety during pregnancy. There have been no adverse reports for like adverse fetal effects, but it's just not used commonly enough for there to be a lot of data. So my personal thought is, if the patient is that hypotensive and has like that low cardiac output, the fetus is probably not going to do that well anyway. So you should optimize their cardiac output and blood pressure as much as you can in order to give that fetus the best perfusion possible. That's my personal opinion. But the other thing I want to highlight here is consideration of mechanical circulatory support. That does not mean that everyone has to have like an ECMO consult or needs to see a cardiac surgeon, but at least needs to be part of your thought process that this person is that bad and is potentially in cardiogenic shock. Whatever is happening to them during pregnancy is potentially reversible, which is one of the big things with ECMO, right? And so if you're not at a place that offers that, at least say, hey, you know what, is this patient potentially a candidate? Could they potentially benefit from it? Do they need to go somewhere that can offer them that? I don't know the answer to that question. It's a very individualized thing. And you might run into surgeons who absolutely hate doing this for pregnant patients because they're justifiably concerned about what kind of outcomes they're going to have. Patients tend to bleed a lot more on ECMO, which is our surgeon's general objection in these cases. But it should at least be part of the conversation if somebody is that severe. And so I have done C-sections in the hybrid room for the express purpose of being right there to cannulate for ECMO in case they really do poorly right after delivery. Thankfully, I've never needed to do it. But I've been in there multiple times, like with the surgeon standing outside the room just in case. So it sometimes does need to be part of the conversation. So I just like to highlight that you should talk about it early if you're going to talk about it rather than waiting until they crash and they're in a really bad spot. As far as arrhythmias, this is just a couple of standard things. These are also from the ESC guidelines, which are super helpful if you're interested in this particular topic or want some place to start. Cardioversion is safe in pregnancy. The voltage that you're applying externally should not make it down to the fetus. They're insulated enough down there that you can use standard voltages. You don't have to alter them because they're pregnant. These are a couple of antiarrhythmics that we use very commonly that are maybe lower on the list in pregnancy than they are otherwise, amiodarone specifically, because it has a lot of fetal toxicity issues. Catheter ablations you can do in pregnancy, but they're usually reserved for refractory or poorly tolerated arrhythmias. Like a lot of procedures in pregnancy, if you don't have to do it, it's better to wait until they're not pregnant anymore. We have done some here. I've been involved in several of them, and thankfully our EP docs now are able to do a lot of them without fluoro, which is one of the main concerns for fetus is radiation exposure. Dr. Castilla can actually do them without fluoro in a lot of cases for pregnant patients, so that makes it a lot more feasible to do. So these are just a summary of some of the recommendations for SVTs and for VTs. So here's the ICD implantation that you should do if you can. Feasibly, a lot of people don't like to do these procedures on pregnant women, so a lot of them will get them immediately postpartum, like in the first couple of days, and they'll just have a life vest if they have an indication for some sort of ICD or shock therapy. But you can see that like beta blockers, calcium channel blockers are generally pretty first line in pregnancy. Digoxin is used probably more frequently than it is in the non-pregnant population. And then you can see in the second line for like the SVTs, there's a lot of like the sotalol and the flecainide and things like that that we actually are further down on the list in non-pregnancy. A lot of these are actually used for fetal arrhythmias, so we actually have more data on them than some other ones as far as their fetal effects. So a lot of moms, if they have a fetal arrhythmia, will take, like the mom will take high dose antiarrhythmics so that it will cross over the placenta and treat the baby, which is not here or there, but that's why we know about them in pregnancy. So, all right, now we're gonna move on to sepsis. You guys hopefully all know what sepsis is. When I trained, it was a little bit before all this like sepsis 3 stuff where they've kind of updated the thinking of it. So it was much more of like a linear progression from like infection to SIRS to surveillance, whatever. So we use SIRS a lot more in the diagnosis. And so obviously now that's not really happening anymore. They have the SOFA score, which was totally news to me when I started thinking about this critical care stuff. But the important thing that hopefully you've gotten from this so far is that sometimes it's really hard to tell if somebody is really sick or is getting septic or things like that. So why do moms die from sepsis? They might have a delayed diagnosis, they may have a delayed treatment or a delayed escalation of care. And I think all that centers around the difficulty in knowing whether or not they're sick. A lot of times these are young, otherwise healthy people who we all know can kind of go to the edge of the cliff before they really show you that they're sick. And then they fall off the cliff and it's hard to bring them back. So this is the SOFA score. I'm going to assume that you guys are all familiar with this and its implications. So there it is. This is the Q-SOFA score, which is the quick bedside screening version of this. In pregnancy, this is not that helpful. They've actually, a couple people have looked at it, and the sensitivity is like 35%. The specificity is like 89%, but the sensitivity is not that great as far as like telling if somebody is very sick or not. And the pregnant patients and the ones that they looked at least didn't have the altered mental status as documented by the GCS. I wonder if part of the reason for that is GCS is not really a typical thing that's done on labor and delivery floors or postpartum floors, so its assessment may not be done as regularly, or people may not be as comfortable with it. But that's what they tended to find. So that using these particular criteria and these numbers did not net you a whole lot of people who ended up like being septic or being sick. So this is SOMANS, which is Australia and New Zealand's version of ACOG, I think, and they came out with this in 2017, which is the obstetrically modified SOFA score. And so they've just kind of altered some of these parameters to be more applicable to the physiology of pregnancy. And so, so this is kind of what they have. It's a little more simple, and some of the numbers are a little bit changed to better reflect the physiology. And then this is their modified Q-SOFA score. And the big things that they've done here is they've altered the respiratory rate to reflect the baseline increased respiratory rate of pregnancy. They've altered the systemic blood pressure, because I can tell you there are a lot of people who are under 100 systolic on labor delivery, and they are not septic, they're just pregnant. So that's true. And then their altermentation, instead of doing a GCS, they just said alert or not alert, and that's way easier for everyone to just do a quick look at a patient and say, hey, something's wrong, like they're not alert, their mental status is altered, without having to do a formal GCS calculation. And so they, I don't know if they have numbers on this. They don't, as far as how accurate it is. But anyway, but this is at least their proposal for the modified Q-SOFA score. And then the other score that exists out there is the SOS score, the Sepsis and Obstetrics score. This was put forth in 2017. They are looking for, you have all these scores and all these numbers, they're looking for a score of 6 or higher before they are kind of concerned that something's going on or you're triggered to escalate care. And what they found was their sensitivity for detecting like someone who's septic was 66%, which is better than 35%, and their specificity was 88%. So it's a little bit better than the scores we have out there. Obviously, there's nothing perfect that's going to tell you, yes, like this patient is definitely sick. Wouldn't it be great if we just had one score that was like yes and no? But we don't. And so finally, I don't know if you guys are familiar with the maternal early warning system. This was originally proposed in 2014 by the National Partnership for Maternal Safety to facilitate earlier recognition of patients who are becoming critically ill. So this isn't specific for sepsis. This is just kind of a marker of like, hey, like things don't seem to be going very well. We need to bring this to people's attention. So this is kind of a bedside thing that the nurses would do as an assessment. And so, like I said, it's based on the idea that 40 to 50% of these deaths are preventable. And so it's an alert system for kind of heightened evaluation. So there's the list of alert criteria right here. And so basically, like, the nurse or whoever's at the bedside would observe and confirm these things, you know, confirm them within 10 minutes. So, like, if this is here and it's just like a transient thing, you have a contraction, your heart rate goes up, like, obviously that's different. But they find these things, they confirm these things, and when you meet your criteria, then you should have an in-house or an attending obstetrician evaluating within 10 minutes. And so I can tell you we have this on our labor and delivery floor. And I don't know if the residents love it because they're going to be called to assess patients a lot. And so what this is designed to do is catch a wide bucket, right? And say they're looking at these patients and they say, no, like this is why this thing is happening, this is fine, versus, hey, this is really concerning, we might need to escalate this further. And so when you're implementing something like this, you have to think about who's going to respond to it, how are they going to escalate things if they feel like things need to be escalated, and also from the nursing standpoint, if they feel like they're being blown off, but they're really concerned something's wrong, what's their mechanism to kind of go around and get their concerns noted also? Because I think we all know that that's a thing. Sometimes the nurses have a better feel because they're sitting there, and so they may be concerned but not be able to put their finger on something. So what's their mechanism to kind of not just say, oh, you have to be really persistent? Like, what's their mechanism to get this evaluated? So causes of sepsis, this is from that chest paper that I've been referencing a lot of potential causes of sepsis and potential organisms causing sepsis. I dislike things like this because it seems so like vague and random. So this is from the Society for MFM Journal of Common Sources of Infection of Sepsis. And this is much less words, and so I like it much better as far as common sources. But you can see there's a lot of obstetric things, and that's probably the most common. Wound infections, choreo, endometritis, like septic abortions, that kind of thing. And then you have your general players that you guys are much more used to taking care of as far as what's causing sepsis. And so this is again from that SMFM article, which I think is really nice, on sepsis and pregnancy. And they just kind of outline the general steps in care, which if you read them, are basically your steps in sepsis care in general. And that's kind of a bottom line here, is that pregnant patients still should get standard of care. You just have to maybe modify some of the steps a little bit to account for their pregnancy and the more complicated thing. But in general, this little category here is kind of the specific kind of fetal pregnancy stuff, but a lot of the rest of it is just sepsis care. So you're starting your broad spectrum antibiotics early, you're doing fluid resuscitation, you're getting labs, you're doing all that basic stuff. And so your broad spectrum antibiotics, for the most part, are what you're going to start anyway. So I'm not going to tell you what to do. I'm hoping that you know that better than I do. For the GU, like the choreo and the obstetric-related infections, AMP and GENT is a common one that I see them do. But otherwise, it would just be kind of what you would normally be covering for like a pneumonia or an intra-abdominal infection or something like that.
Does ionbeta-methazone count as like streptosteroids for the mom, or is it just for fetal lumbar?
It's just for fetal lumbar, okay. Yeah. So hypertensive disorders of pregnancy. So I'm guessing in the neuro ICU, you might see some of the spectrum. This is maybe more relevant to you than it would be to some people. But this is your spectrum. It is, as I think with most things now, like we just talked about sepsis, it's being seen more as a spectrum than like buckets of diagnoses. So you've got pregnancy-induced hypertension, you have preeclampsia, and you have eclampsia. And again, from when I was in medical school, the terminology has changed a little bit, so no longer do they call it mild and severe preeclampsia. It's preeclampsia either with severe features or without severe features. And the severe features, you either have to have proteinuria greater than 5 grams a day or some sign of end organ failure or damage, like kidney dysfunction. Headaches is a big one, kind of neurologic dysfunction. That's a big one everyone's really worried about. You can have pulmonary edema. You can have a lot of different things. You can have renal dysfunction. You can actually have fetal distress, which we said is kind of at least a measure of perfusion to something, even if it's not an organ. Another thing to note is that for the diagnosis of preeclampsia, it used to be required that you had proteinuria, and so if you didn't have it, but that's no longer true. You can have hypertension plus a severe feature without proteinuria and still qualify for a diagnosis of preeclampsia and be treated that same way. Or you can have proteinuria and like a milder range blood pressure. And then HELLP syndrome is everyone's least favorite thing ever. It's a variety of severe preeclampsia, but the important thing to note about that is that like 15 to 20% of them are actually not hypertensive. So they have hemolysis, elevated liver enzymes, and low platelets, but may actually not be hypertensive. So you have to be careful about that in saying, oh, their blood pressure is normal, so they can't have preeclampsia. That is not necessarily true. And obviously, eclampsia is diagnosed based on the presence of seizures in the setting of preeclampsia. Every once in a while, that will be your first presentation, is you meet a patient having a seizure. They had preeclampsia. We did not know that. And then pregnancy-induced hypertension, a lot of people have this, people with chronic hypertension or increased risk for a lot of this stuff, but if it's pregnancy-induced, the onset has to be past 20 weeks of gestation. So if they come in for their first prenatal visit hypertensive, then the assumption is that they've just had chronic hypertension. So what do we do about it? So there are kind of 4 major tenets of therapy for preeclampsia. The first one is blood pressure control, and so I've kind of listed the medications that they'll commonly use up on the labor and delivery unit at least, as far as controlling blood pressures. If they make it to you, then they might need more of a continuous infusion of something if it's refractory, but these are the kind of things that we start with. The second is seizure prophylaxis, which is magnesium. Hopefully you guys all remember that stuff. The therapeutic level is 4 to 7, but you have to be careful and kind of check levels constantly because it can cause pulmonary edema and arrhythmias and cardiac arrest if you let it go out of control. And it also makes people feel awful. They cannot get out of bed, they are woozy, like they just feel terrible. So just know that if they're awake, like they are going to feel really bad if they're on magnesium. And also if somebody is in renal failure, which is totally a thing that can happen in preeclampsia, that's one of the end organ damages. The magnesium can actually accumulate, it's not cleared as much, and so we've definitely had patients who have super therapeutic levels despite a reasonably normal rate because they're not clearing it as well, so that's another thing to keep an eye on. If they do have a seizure, how do you manage it? We talk about this with all of our residents and students, and number 1 is going back to the basics, doing your ABCs. So just stabilizing the patient. If you need to control their airway, control their airway. Just making sure that you're supporting them through that event. IV magnesium is important. If you need to terminate the seizure acutely, you can use something else like benzodiazepines or traditional anti-epileptics, although they don't really have good data in preeclampsia as opposed to other types of seizures. It's always like a debate afterwards that I don't take part in. But you are welcome to if you want. But magnesium is really the way to go in a preeclamptic or eclamptic seizure. And then the last thing is delivery, right? A lot of I'm not going to go into the underlying causes of preeclampsia, but it's thought that the underlying cause is kind of the way that the spiral arteries of the placenta implant and affect the blood pressure. And so theoretically, delivering the baby and delivering the placenta is the best treatment for preeclampsia. And this goes back a little bit to the benefit of keeping mom pregnant for baby versus the benefit to mom, because sometimes if they're very severe and they present like in the 20s of gestational age, do you just try to stabilize them and keep them pregnant? Do you just stabilize them through their steroid window, get the steroids on board, then deliver baby, or do you deliver them right now because things are so severe? So that's always part of the conversation. So if they can get steroids on board, that is always preferable for baby's well-being. But at some point, like if mom gets really sick, then you may just have to move on without that. And so in really sick, by the way, I'm not an obstetrician, I can't exactly tell you, but if their pressures are very difficult to control or if they're really showing signs of end organ damage that they can't make better, so like if a headache is persistent, they're more likely to say, hey, I want to deliver earlier. If like their kidney function's worsening or something like that, they may be more likely to say, hey, I want to deliver sooner rather than later. So that's the kind of thing that may make them want to move forward despite not getting through that steroid window. And finally, I think this is the last cause. I have postpartum hemorrhage. Sorry, I know it's 2 o'clock, but I still have all this stuff left. If anyone needs to go, you can go. If not, I can keep talking. So these are some of the major causes of postpartum hemorrhage. Uterine atony is about 80% of postpartum hemorrhage. That's by far and away the most common thing you're going to see. Other obstetric causes like lacerations or retained products at conception, abnormal placentas like a placenta accreta are other causes. Medically, we can manage it with medication. So oxytocin is something that most people who deliver will get prophylactically, at least to help prevent this. Some of these side effects I put, this is part of my cardiac talk, so they're kind of like things to watch out for in sicker patients or volume overloaded patients or kind of cardiac patients that are potential. But these are some of the other medications that we can use. Tranexamic acid is like the new big thing that's making its way onto a lot of postpartum hemorrhage protocols. Kind of similar in trauma, if somebody has kind of a severe thing, it's not the first line thing, but if you've given multiple agents, they're still bleeding, you would kind of bolus a gram over about 10 minutes, repeat the dose in 30 minutes like you might do for a trauma. This is based on the woman trial from 2017, which was shown to decrease maternal mortality in the setting of postpartum hemorrhage. If you are not familiar with the way this trial was conducted, a lot of this research was actually done in countries with more limited resources. So they don't have all the medications that we have necessarily, and their postpartum hemorrhage protocols are different. And so one of the big criticisms in the study is that may not be as relevant to places like us because we have all these other steps that we can do first as opposed to that. So while it did certainly show a significant effect, that effect may have been due to the population it was studied in. Regardless, we still are putting in all our protocols because, you know.
Well, when this happens, they're getting all these drugs like immediately.
It's all happening. It's like a trauma. Like everything's happening.
And
at the
they're
same
still
time.
bleeding after 4 drugs, and
Right, they're getting TXA.
Yeah.
Yeah, they're getting the TXA. This is just an example of our massive hemorrhage protocol. We have a specific OB one here, so if you are massively transfusing someone, make sure you ask for the OB specific one, and the big difference is they will send you cryo automatically without you having to ask for it. So that goes back to the fibrinogen we talked about earlier. I'm going to skip these because nobody cares.
I'm here.
All right, fine. There they are. These are non-pharmacologic things you can do for postpartum hemorrhage. These are mostly the OBs are going to do. I think the one you guys might see the most is if someone comes to me with a Bacri balloon in place. It's just like a balloon that you blow up in the uterus that tampons off the blood vessels there, and they'll keep it up for like 12 hours, 24 hours, and then like slowly take it down and see how it goes and see if they bleed. So you may have someone with that in place in the unit, and that's all it is. It's just a balloon that's blown up in the uterus to tampen it off and just hopefully give it time because time helps a lot of things. All right, I'm going to go through this really, really fast. Maternal cardiac arrest is unfortunately something you might have to deal with in the ICU, and so I'm just going to go over a couple of things. 1 in 12,000 admissions is about the estimated incidence of admissions for delivery in the United States, but maternal near miss during admissions is as high as 1 in 141, which is why we went through all of those scores and maternal early warning systems, all that stuff to try to prevent that. The good news is survival to discharge is greater than 50%. How many of your populations can you say that about? Like nobody, they're terrible. Right, but greater than 50% of these people actually might survive to discharge, and this is in multiple analyses. So this is an anesthesia-related paper, but they went through and looked at basically the national inpatient sample and analyzed causes of maternal arrest during admissions for delivery. And so they found that these certain medical conditions were more likely to be associated with maternal cardiac arrest. Shocking, pulmonary hypertension is up there, congenital heart disease, malignancies, ischemic heart disease, right? These are not surprises to anybody. But these are people who are at a higher risk to have a cardiac arrest during pregnancy or during their admission for delivery. And then I really like this. They break it down by condition for survival, and so you can see what conditions are higher or lower for survival. So the higher survival, you get anaphylaxis, you get mag toxicity, right? We talked about that for preeclampsia, aspiration, anesthesia complications. A lot of anesthesia complications that see are high neuraxial blocks. And so the block goes up too high, patients can't breathe, it gets to a certain point, they arrest. We're able to rescue them quickly. Obviously, that's not ideal. That's not super common. But that's what they need. Even heart failure is like 71%. The lower survival stuff is the kind of stuff that we see in cardiac arrest in a non-pregnant population. The trauma, the aortic dissection. Like if you code from that, that's not good. You're not going to do very well. Thromboembolisms, acute MIs, like those are more of the things that you see in the general population that doesn't do as well, whereas the people who survive more are the ones who are slightly more specific to the OB population. So the AHA, this is from 2015, has a statement on cardiac arrest in pregnancy, and so the important things to note are, don't change a lot of stuff. Still give them CPR like you give them CPR. Still do the same rate and depth and position for chest compressions. No modification of defibrillation during pregnancy. Don't change your voltages. Don't change your medications at all. They specifically say, like, don't withhold medications because you're concerned about fetal toxicity. If mom dies, the baby's gonna die anyway, right? That's the point. Their institution should have a specific maternal code blue team that gets activated when a mom codes versus when anyone else codes, and OB should be on that team so that they automatically get called to the code. Because one of the important things that you have to do during a maternal code blue is prepare for a perimortem C-section. And the official recommendation is that if you have not gotten ROS within 4 minutes, you should start prepping for that. And the goal is to have baby out by 5 minutes. And that actually infers a survival benefit on mom. Because you've basically taken this cardiac output sink out of her and improved her chance for survival. And it probably improves survival of the baby, because if mom is not going to survive, at least you've separated the baby from that and given it a chance to live outside. The other alteration that you need to know about is the continuous left uterine displacement. Because if their gestational age is past about 20, which you can tell because the uterus would be about the level of the umbilicus, it can compress your IVC or your aorta, and it can impair your cardiac return, your venous return. And so if you displace it and allow blood to come back to the heart, then they're probably going to do a little bit better. That's what that looks like. These are your two options. This one is preferred to have somebody do it manually, because you can imagine how long it takes to build this thing and how it interrupt chest compressions to do that. So if you just have somebody, I envision them crouching at the side of the bed, just kind of holding the uterus out of the way. It's probably faster and more effective. This is from our Society for Obstetric Anesthesia's statement on cardiac arrest. This is just a mnemonic while you're thinking of your H's and T's and general causes for cardiac arrest. Also consider some of those more pregnancy-related ones. So placental issues, preeclampsia, cardiac disease, uterine atony, things like that that are more specific to pregnancy. So this is just a mnemonic that you can use that clearly you remember after seeing it for 2 seconds during this lecture. And this is it. These are just some practical tips for the ICU. A lot of this stuff I think is things that ICUs are starting to do anyway, but for blood transfusions, Rh negative blood is preferred if you can't give type specific blood. And if mom is Rh negative and she's had some sort of trauma or anything, does she need Brogan? And so the concern is for alloimmunization, which will not affect this pregnancy, but the next pregnancy. Because if mom forms antibodies against whatever she was transfused against, those antibodies then cross the placenta in a next pregnancy and can cause fetal anemia and all sorts of bad things to happen. So that's why, even though I'm sure we've all gotten emails about shortages of O negative blood and it's only going to be for like women of childbearing age, like that's why they reserve it for that population if it's short. Be mindful of radiation. I think that this is where ICU practice is going in general, but I remember as a med student, like everybody just got a daily chest x-ray no matter what. And these people probably do not need a daily chest x-ray no matter what. And that's not to say that they can't be exposed to ionizing radiation, but it should be a risk-benefit ratio thing. Like if it's really going to answer a clinical question, then you should do it. But if this is just to confirm like that your tube is still in the same place that it was yesterday, probably you can skip it unless you're concerned there's really a problem. So just kind of think about things like that. And if you're going to put in a central line, a femoral line is probably not going to be as good as you think it is. I know we stay away from those anyway, but they're more likely to be compressed by the uterus. They have an increased risk of thrombosis in the leg from a DVT, and they're not going to help if they're bleeding because it's all just going to go right into the abdomen anyway. So IJs and subclavians are pretty much preferred if you're going to have access. This is just people who study pregnant women and can give you more information if you're interested. And that's it. Sorry, that was a lot. Questions?
Do you give intralipid in pregnancy or last, just like you would normally?
Yeah, we do. There's not really great data on it, but basically, if it's like if you're having an arrest from it, then you basically just give it the same way.
And then, do you know if you can put an OB stat anywhere in the hospital, like you would in an ED?
I imagine that you can.
Just like put the room number wherever you think.
Yeah, I would think so. I mean, obviously they're most common in the ED and like on the 3rd floor, but I'm fairly sure that you can. I've never tried it. I feel like it should work. I mean, I know if you call like a maternal code blue, it should be able to be anywhere. They just may not know where you are. So.
I don't know if you already brought this up as a human.
That's okay.
There's a classic board question that they, not talking about the daily chest x-rays or radiation, but trying to rule out a PE, study of choice of the CTPA, not a B2 state.
Yes. Yeah. And I think that's actually because the radiation is higher for a VQ scan. I think I give another talk somewhere else where I actually give like more specifics of radiation and doses, because the American College of Radiology actually has stuff published where they give like radiation doses for various studies. And the bottom line is that no one study actually crosses the threshold for like concerning radiation exposure in a fetus. So if you need to do something, you should do it if it helps with the treatment of the mom. But I think VQ scan was higher.
Yeah, they always try to lead you down to, oh, don't do a CT.
Yeah.
Do it if you're concerned about a TE.
And also, I mean, I don't do these a lot, but my experience is that VQ scans are much more wishy-washy as far as actually diagnosing things. And so I feel like you should do the study that will help you the most and has less radiation.
That's because the VQ scans will come back as either low, intermediate, or high probability, and sometimes.
And you can imagine a pregnant person with the lungs all squished up anyway. It's not going to be as clear as it would be otherwise. That's my guess. It's not based on anything. So.